Bismillahirrahmanirrahim. Good evening, everyone. It is my absolute pleasure to welcome you to the second MSART webinar for this year, proudly held in collaboration with BSV. I am Dr. Muhammad Hattar from Sabah Care Fertility and Special Center, Kota Kinabalu, and I will be your moderator for today. Before we dive into the exciting discussion ahead of the role of Dienogest in IVF for the endometriosis patient, with our esteemed speaker, Dr. Maria Victoria Romualdez, I'd like to take a moment to acknowledge the incredible initiative MSART has planned for this year. MSART's mission is to elevate fertility practice in the region and beyond. Over the years, MSART has positioned itself as a leading voice in reproductive medicine, not just in Malaysia, but on the global stage. Building on this spirit of collaboration and innovation, I am thrilled to share that MSART is partnering with the Pacific Society of Reproductive Medicine, or PSRM, and the International Society for IVF, which is ISIVF, to host the 14th Congress of the Pacific Society of Reproductive Medicine, or PSRM, in 2025, this year. This prestigious event will take place on the 7th to 9th of November 2025 at the Sunway Pyramid Convention Center, or SPCC, right here in Malaysia. The PSRM Congress is a biennial gathering that unites the brightest minds in reproductive medicine from across the Pacific region and beyond. This year's theme, Elevating Fertility Care, Innovations and Impact, reflects our shared commitment to exploring groundbreaking advancement and transformative changes in fertility care. I am confident that a thoughtfully prepared agenda featuring engaging topics and an exceptional lineup of speakers will inspire meaningful discussion and further strengthen our collective dedication to advancing fertility care. Our PSRM 2025 website is officially launching today, and we are now calling for abstracts. You may submit your abstracts through our website. Additionally, we will be hosting monthly webinars this year, and our next webinar will be featuring Dr. Susana Montenegro Guevia, will be held on the 11th of March 2025. We invite you to register once registration opens soon. Now, let us move on to today's agenda. We will begin with a presentation by Dr. Maria Victoria Tan, followed by a Q&A session. Feel free to submit your questions in the Q&A box while Dr. Maria is presenting. Before we begin, allow me to introduce our distinguished speaker briefly. Dr. Tan is a medical director of Repro Optima Center for Reproductive Health and the scientific director of ACCU-ART Fertility Center. With over 20 years of experience in reproductive medicine, she is a recognized authority in fertility care, combining advanced clinical expertise with a patient-centered approach. Dr. Maria holds a master's degree in biotechnology and human-assisted reproduction from the University of Valencia and certifications from Harvard Medical School, reflecting her dedication to continuous learning and excellence in the field. Dr. Maria's career is marked by numerous achievements, including winning the prestigious Capstone Award for her research in endometriosis-associated infertility. She has gained international experience through advanced training in Japan and Australia, and is a sought-after speaker and a published researcher. Her work in integrating innovative technologies such as AI in reproductive medicine has positioned her as a leader in advancing fertility treatment and improving patients' outcome. Now, with that, I would like to present to you Dr. Maria Tan. The floor is yours.
Thank you, Dr. Hatta, for the very kind introductions. And it's an honor for me to be joining my colleagues and friends from the Malaysian Society of Assisted Reproductive Technology. So I would like to thank the organizers and the sponsors for this opportunity. So I'd like to share my slides. So can you see my slide? I'd like to get a confirmation.
Yes, we
Yeah,
can.
so thank you. So I'm lecturing on a topic, or the title of my lecture would be the role of Dienogest in IVF for the endometriosis patient. So these are my disclosures. And for tonight's webinar, I would like to go through a brief overview of the pathogenesis of endometriosis and its medical management. Particularly for this lecture, we will be focusing on progestogens and its mechanism of action, and particularly the progestogen Dienogest. But the main bulk of the webinar will be focused on presenting evidence which will answer the question, is there a role for Dienogest in IVF for patients with endometriosis? And I would like to categorize the evidence into three parts. First is giving Dienogest prior to IVF. Second is the role of Dienogest during IVF. And third is Dienogest after OPU, but before embryo transfer. So let's start with something that everybody already knows. We know that endometriosis is a debilitating condition, and it affects up to 50% of patients with infertility. And that is the reason why I'm sure all of you here, clinicians, are very familiar with the disease. And you would also know that its etiopathogenesis is very complex. So it's defined as the presence of functional endometrial glands and stroma growing outside of the uterine cavity. And the World Endometriosis Society had already proposed that endometriosis has multiple pathological factors, and these include specific genetic features, immune abnormalities, hormone imbalance, hemorrhagic factors, and some organ-dependent diseases. Okay. So I'm presenting this from the paper of Shi and colleagues that was published quite recently in Frontiers of Pharmacology in 2023. And you can see here that there are several mechanisms involved, but I just wanted to point out that the mechanisms actually interact or intersect through inflammatory agents such as tumor necrosis factor alpha and interleukin beta, as well as PGE2 and cyclic AMP. So because they intersect, it becomes a vicious cycle. So we don't even know sometimes how it started, which one is really the triggering event, but bottom line is it can propagate itself by the interconnecting mechanisms. So medications that are targeted for endometriosis actually work on these mechanisms. And surgery is one aspect, but really medical treatments are the ones that are used to address these etiopathogenetic mechanisms. So we have among the most common medical treatments your progestogens, GnRH agonists, your antagonists, NSAIDs, EP4 receptor agonists, selective progesterone receptor modifiers, selective estrogen receptor modifiers, your aromatase inhibitors, and immunotherapy. But for this evening, we would just like to focus on the mainly the progestogens, okay, and the particularly Dienogest. So how do progestogens exert a therapeutic effect on endometriosis? So the same paper from Shi and colleagues demonstrated that there is modulation of estrogen receptors. There's inhibition of inflammatory response. Progestogens also prevent endometrial proliferation, and they promote apoptosis of the endometrial cells. In a paper by Verschellini, published in 2011, it's a very old paper, but basic science research showed that the progestogens also reduce oxidative stress by reducing uterine bleeding in endometriotic lesions. Gezer and Oral, and as well the paper from Casper also showed that progestogens stimulate atrophy or regression of endometrial lesions. They inhibit angiogenesis. They reduce the expression of metalloproteinases. They reduce the invasive ability of endometriosis implants through this mechanism. And also they reduce pulsatile GnRH release, thus affecting a decreased FSH, LH, and estrogen. Now, depending on which type of progestogen, they actually have different properties. So the types according to the source, and the three basic sources are your 19-desmethyl testosterone derivatives, progesterone derivatives, and spironolactone. Now, what about Dienogest? Let's discuss Dienogest. So Dienogest is a fourth generation selective progesterone that is actually the progesterone that is marketed for the treatment of endometriosis. It's a 19-nortestosterone derivative, and it combines the pharmacological properties of two kinds of derivatives, the 9-desmethyl testosterone derivative and the progesterone derivative. And as such, they have those combined effect of exerting a very efficient progestational effect or progesterone-like effect, but without androgenic effect. And although it inhibits the HPO axis moderately, there is really only moderate reduction of estrogen, glucose, salt, and lipids. So as such, it's very well tolerated by the patients. Okay. And those properties actually is because of the molecular structure of the Dienogest. The addition, so here is the structure of the Dienogest, and the addition of a double bond in the 9th position actually makes it more progestational. It increases the progesterone activity, and the replacement of alkaline with cyanomethyl at 17 alpha position enhances progesterone activity as well, but it has very little androgenic or corticosteroid activity. Again, that's the reason why it is well tolerated. Okay. Now, in vivo, what are the effects of Dienogest? So a paper by Foster and colleagues showed that Dienogest actually exhibits very well pregnancy-like effects. And it also inhibits the release of gonadotropin, but without glucocorticoid, mineralocorticoid, and estrogen-like effects. Stravitsky and Faustman and colleagues actually also showed that the Dienogest exhibited better therapeutic effects in endometriosis patients compared to placebo. Okay, but if you compare it to GnRH agonists, it is actually of comparable effect, but with better tolerance. So the main question is, we know that Dienogest is very effective for endometriosis, but can we, or does it have a role for women with endometriosis who are going to undergo IVF? And I would like to actually divide the evidence into three parts. First is the role of Dienogest prior to IVF. Second is during IVF. And the third is after the egg pickup, but before embryo transfer. Okay, so let's start with the first part. Is there a role, or are IVF outcomes improved with the Dienogest treatment prior to IVF? The best evidence for this is actually a paper by Valeria Muller and colleagues from Russia. They published this in 2021. And the title is The Dienogest Treatment After Ovarian Endometrioma Removal in Infertile Women Prior to IVF. This was a prospective cohort study involving 144 infertile women planning to do IVF after laparoscopic surgery for ovarian endometriomas. This study population were divided into three groups. The first group received Dienogest prior to IVF. The second group received GnRH agonist, and the third group had no hormonal therapy within the 6 months preceding IVF. They wanted to look for the primary outcome, a comparison amongst these groups in terms of clinical pregnancy. But because they also followed through these patients until delivery, they also noted the live birth rates. The secondary outcomes were total recombinant FSH dose, duration of stimulation, the number of follicles, more than 1.4 centimeters at the time of ovulation trigger, the number of cumulus oocyte complexes retrieved, and the number of good quality embryos on day 3 of culture, and also the cycle cancellation rate. So let's look at the results of this study. Amongst the groups, there were similar baseline characteristics in terms of size of endometrioma, laterality, ovarian reserve indicators. And for their primary outcome, which was actually clinical pregnancy rate, you can see that there was a significant difference. It was 2.5 higher, the clinical pregnancy rate in the Dienogest group versus those who did not receive any treatment. But if they looked at the agonist group against those who received no treatment, there was still a higher pregnancy rate, but this was not significantly different. Now, the live birth rates show the same pattern. Dienogest versus no treatment showed a 3 times higher live birth rate, but the GnRH agonist versus no treatment showed some difference favoring GnRH agonist, but this was not statistically significant. So as far as the secondary outcomes, you can see that as far as the total dosage of gonadotropins, the number of days of stimulation, the number of COCs retrieved, and the number of good quality embryos on day 3, there was actually no difference between the Dienogest and the GnRH agonist group, but you can see that comparing between agonist and no treatment, as well as the Dienogest versus no treatment, there was really a significant difference favoring treatment groups, the Dienogest and GnRH agonist. Okay. And in terms of cycle cancellation, sorry, this was mostly due to poor response to stimulation, and there was really a 4.5 times higher cycle cancellation in the no treatment group versus the Dienogest group, and a slightly lower, although still between GnRH and no treatment, there were more cancellations in the no treatment group against the GnRH group. Okay. So in conclusion, the study confirmed that the necessity of pre-cycle medical interventions in women with ovarian forms of endometriosis undergoing IVF. And the authors suggest that the Dienogest is possibly the more efficient treatment option for these kinds of patients. Now, later in 2023, so much later than this publication by Molière, a group from Taiwan, Wen Jingxiao and colleagues, published a systematic review and meta-analysis entitled Impact of Dienogest Pretreatment on IVF Embryo Transfer Outcomes in Patients with Endometriosis. So they looked into a lot of things, but I just wanted to focus on the clinical pregnancy rates and the live birth rates. So you can see that both clinical pregnancy rates and live birth rates actually had a relative ratio that is higher than 1. So for clinical pregnancy rates, it's 1.26. So that means that there was it's a 26% higher pregnancy rate in the Dienogest group over the non-Dienogest group. So remember, this is not necessarily a no treatment group. This is a non-Dienogest group. So for example, in the paper of Molière, as we mentioned earlier, there were 3 groups. So the non-Dienogest group were lumped into one, GnRH and no hormonal treatment. In Tamura's paper, however, it was just a comparison between the Dienogest group and the GnRH agonist group. Okay, but all in all, if the authors looked at both clinical pregnancy rates and live birth rates and comparing it to no hormonal treatments, this is their conclusion, that clinical pregnancy rate and live birth rates after the Dienogest treatment is significantly higher than those after non-hormonal treatment, and that these findings indicated that the Dienogest may be a preferred treatment over non-hormonal treatment to improve the clinical pregnancy rates and live birth rates. And this drug might be used alone, not necessarily in combination with GnRH agonists or any other treatments for patients with endometriosis who would undergo IVF embryo transfer. Okay, but they also said that more evidence is warranted to corroborate these findings. Okay, so let's leave the part about the Dienogest being used prior to IVF, and let's go to the Dienogest being used during IVF. So the question is, our IVF outcomes improved with continuing Dienogest treatment during ovarian hyperstimulation for IVF. Okay. So the reason for this question is because conventionally, what we have been doing is that when patients who have endometriosis are on certain treatments, some of them are on Dienogest, usually we let them stop those treatments before they start assisted reproduction, right? But the problem is that when doing so, we notice that seems to be a recurrence of dysmenorrhea and also endometriosis progression. So the question really is, can we continue Dienogest when doing IVF? And this question had arose because recently there is an increasing popularity of the progestin prime ovarian stimulation protocols, right? So uh, there is already proof of concepts that that progestins is a good way of suppressing the LH surge. It can replace the antagonists and the agonists. And so the question now is, can the Dienogest be the progestin used for this protocol? And therefore, if they were previously on the Dienogest before, then they will just continue the Dienogest throughout the treatment. So let's look for evidence on this. So the most well-written evidence I could find is actually a paper from Nanako Iwami and colleagues from the Kamiya Ladies Clinic in Japan, in Hokkaido, Japan. And this was in 2021, published in Reproductive Biology. Okay. And their study was a prospective cohort parallel group non-inferiority trial involving 150 women with endometriosis who were undergoing IVF. They divided the population into the Dienogest group, which had 73 patients, and the dydrogesterone group, which had 77 patients. So at this point, I wanted to say that the comparison was between Dienogest versus dydrogesterone in a progestin prime ovarian stimulation cycle. Okay. And this was the controlled ovarian hyperstimulation protocol that they did. So you can see that in the Dienogest protocol, patients were already on 2 milligrams per day of Dienogest and just took it continuously, okay, throughout the entire COH cycle. And in the dydrogesterone protocol, there was a stop of the treatments prior, and then they just resumed the progestin dydrogesterone during ovarian stimulation and started it on about day 2 or 3. Okay. And in this study, the patients were given a dose of HMG between 150 to 225 IU and were triggered with either GnRH agonist or HCG. The main outcome that they wanted to look at were fertilization rates, and the secondary outcomes were the mature oocyte rates, the number of viable embryos, the clinical pregnancy rates, the ongoing pregnancy rates, miscarriage rates, and the cycle cancellation rate. Okay, so this is the patient's flow chart, and from here you can already see that 54 patients out of 100, 54 out of 100, or there was 54 clinical pregnancies out of 107 FET cycles in 67 patients, resulting in 36 live births. Whereas in the dydrogesterone group, there were 59 clinical pregnancies in 126 FET cycles out of in 66 patients, and 45 of these patients resulted in a live birth rate. So remember, this is a non-inferiority trial. So they wanted to make sure that the results were not necessarily superior for the Dienogest group, but non-inferior. Okay, and you can see that the main outcome was fertilization rate, which there was no difference between the two groups. But interestingly, I wanted to show you that the mature oocyte rate was significantly higher in the Dienogest group. Okay, and when you look at pregnancy outcomes, you can see that pregnancy rates, okay, clinical pregnancy rates, and live birth rates had no significant difference between the two groups. And so the conclusion of the authors was that patients taking the Dienogest for PPOS can continue endometriosis treatment and obtain good quality embryos during controlled ovarian hyperstimulation. Okay. Another evidence that would support using the Dienogest during IVF was not really a publication, but it was an oral presentation in the 2023 American Society of Reproductive Medicine meeting at New Orleans. Okay, and this paper was from Buojia Lu and Chi Huang Chen. Also, I think this is also from Taiwan. And the title was Dienogest as a feasible alternative for luteinizing hormone suppression in progestin prime ovarian stimulation. So their study was a retrospective cohort study with the objective of determining whether Dienogest can be used as an alternative progestin in PPOS. But the comparison group in this study, unlike the one by Iwami, which was dydrogesterone, here the comparison group was medroxyprogesterone acetate, which is actually one of the first progestins used during the proof of concept papers for progestin prime ovarian stimulation. Okay, and this involved 106 women undergoing IVF. 65 were in the Dienogest group and 41 were in the MPA group. The results showed that, well, both groups were comparable in baseline characteristics. And although the number of oocytes retrieved was smaller in the Dienogest group, the numbers of all cryopreserved embryos were similar, okay? And the total stimulation days and gonadotropin doses were also similar between groups. And likewise, the clinical pregnancy and live birth outcomes from the first frozen thawed embryo transfer cycle was also the same for both groups. So these were just actually the two evidence I could see with the Dienogest being used during IVF. And so I thought this topic is a good research space for which we can actually conduct more research on. Okay, so hopefully there will be many who will be collaborating on such study. So again, in conclusion, the study showed that the Dienogest may be a feasible alternative in PPOS, and compared with MPA, the Dienogest may better suppress premature LH surges without compromising IVF outcomes. So let's move on to the last but not the least role of the Dienogest in IVF. Can we give it to patients, or should we give it to patients after oocyte retrieval but before embryo transfer? Will the IVF outcomes be improved if we gave pre-treatment with Dienogest before frozen embryo transfer for patients with endometriosis? So let's look for answers to that. So actually, for endometriosis, I did not see any published data available, particularly on this topic at the time of this lecture. But I did find some data available on the topic for adenomyosis. So we'll look at that because you see endometriosis and adenomyosis may have similar pathogenetic mechanisms. And so maybe the studies on adenomyosis can be used also for patients with endometriosis. So this is a publication by Min Fang and colleague from in the Taiwanese Journal of Obstetrics and Gynecology Journal, and this was published in 2022. So this is actually a case report and a literature review entitled Segmented In Vitro Fertilization and Frozen Embryo Transfer in Dienogest-Treated Patients with Adenomyosis. Okay, and the other study is this one is from Irina Pacu and colleagues, entitled The Effect of Treatment with Progestins and Antiplatelet Agents on IVF in Women with Adenomyosis and Recurrent Implantation Failure. So actually in both studies, they actually used the Dienogest, and their conclusion was that the Dienogest, a novel progestin, which is a highly selective for progesterone receptors, may benefit pregnancy outcomes of infertile patients with adenomyosis adopting segmented IVF with embryo transfer. So this was a similar conclusion for the study by Paku and colleagues. So again, I would say that there is a knowledge gap when it comes to this question. And again, this is a topic that warrants further research. So in summary, I'd like to close saying that endometriosis is a debilitating disease and it is prevalent among patients with infertility. And Dienogest is an effective treatment for endometriosis. The role of Dienogest in IVF for the patients with endometriosis can be categorized as treatments prior to IVF, use in PPOS during IVF, and pre-treatment prior to FET. So some evidence are available for the use of the Dienogest prior to IVF and for PPOS during IVF, but there's limited evidence that exists for its role prior to frozen embryo transfer. More research is therefore warranted on this topic, and I'm very, very grateful for the opportunity to talk about it with you, and even though it's a relatively young topic, but thank you very much.
Thank you very much, Dr. Tan. You said it so eloquently, dividing the use of Dienogest pre-IVF and during IVF and post-IVF, not only for endometriosis patients, but also for probably other patients as well. For those who have questions, you can post your Q&A questions at the Q&A box. Yeah. So I will start off with the first question. This question says that I prefer dydrogesterone compared to Dienogest for its non-inhibiting natural ovulation, hence patients have menses in PPOS. What is your opinion about dydrogesterone compared to Dienogest in PPOS, Doctor?
That's a very, very good question because, and it's very valid too, because if you look at the studies by Iwami and even the comparison of the Dienogest with MPA, there really is a lower number of M2 sites that are retrieved for during if we use the Dienogest. However, that is actually our goal is to be able to really continuously suppress the endometriosis. And because your number of embryos that are produced, viable embryos produced, and also the clinical pregnancy rates are similar between the two groups, as according to Iwami and colleagues in that paper, I would say that because these patients have endometriosis, for the patient with endometriosis, I would prefer to use the Dienogest. Maybe if she did not have endometriosis, my preference is probably not Dienogest. I'd go for dydrogesterone or MPA. But for the endometriosis patients, Dienogest may have some benefit over the other progestins.
Yes, exactly. Thank you very much for your answer. Now I have another question from Dr. Viniswaran. Hi, thanks for your informative talk. I would like to ask, in patient planning for FET, frozen embryo transfer, after Dienogest treatment, post-OPU, any suggested duration before starting the HRT for the FET?
Okay, so as you see, there's very limited evidence of giving treatments, pre-treatment of endometriosis prior to FET. But if you're asking what I would do for my patients, conventionally, I would treat. I would downregulate endometriosis prior to FET. And that's really because of the evidence showing that the activity of the endometriosis can worsen, the immunologic factors. It may interfere, in fact, with the window of implantation. There are many studies. There was a pre-congress in ESHRE, a presentation by Dr. Andres Salumets, and he actually showed that there is an effect of endometriosis on the window of implantation. So knowing the basic science, it seems just the right thing to do to actually do downregulation. Now, which medication to use, that really remains as an area for research. But I personally have extensive experience using GnRH agonist, and I would keep at least 3 months of the treatment. So one depot or 11.25 milligram dose of GnRH agonist. And then I would let the patient go for a menstrual bleed by giving her at least 2 weeks or 3 weeks of a pill, and my preference is Yaz or drospirenone containing low dose estrogen containing oral contraceptive. So that's how I do it. But really, there's so much room for research on the topic, and it would be nice if we see some papers from Malaysia as well.
Yes, of course. Yes, definitely. That more research needs to be done, and I agree
Yes.
with you that. Another question here from Dr. Sarah Mubarak. How to start IVF PPOS cycle with Dienogest for patients already on Dienogest? No menses, only spotting. Thank you.
So that's actually a random start type of protocol. So you can start anytime. Some would prefer to make sure that there's no follicle. So we all know as clinicians, occasionally we do see some follicles uh, growing, although not really maturing fully when we give the Dienogest, especially patients who are on it on just the few months of the treatment. So some would wait. The others would give an antagonist for 3 days just to make sure that this follicle is not going to suppress or have any effect on the rest of the growing follicles. But yes, it's like a random start. So all the principles of random start can be used for that.
Following that answer, there's a question here on random start PPOS protocol. The consumption of Dienogest can be taken continuously until cryopreserved embryos are obtained, and of course, and or must stop or must we stop the Dienogest after 3 months, like a pre-treatment protocol?
So yes, because it's a progestin, we know that progestins, the timing of giving the progestins is very important in the window of implantation. So we need to stop it before preparing the endometrium. So usually, like I said a while ago, I would prefer at least a 3 month period of treatment prior to planning an embryo transfer, whether it's a GnRH agonist or Dienogest. I would want to induce a withdrawal bleed so that I'm very sure that, this is new, thin endometrium, and then start to build with hormone replacement after that.
Yeah. Okay, good. I have a question here from an anonymous attendee. Thanks for the excellent talk. Why do you think there were more M2 in Dienogest group versus the generic group in pre-treatment group?
So I would like to correct that. There's actually more M2 in the other group, or sorry, more oocytes in the other group, but more M2s,
The Dienogest.
yeah, as a rate or in comparison to the total number of oocytes retrieved. Um, I think that what it only means is that although we might be getting different cohorts. So if you've been doing a lot of PPOS, you know that we don't have a uniform cohort of follicles, right? So you'll have some follicles that are bigger, some follicles that are smaller. And so if the patient had not been downregulated prior, you can have a lot of these larger follicles, smaller follicles. So you have a lot of follicles. Whereas in the Dienogest group, because there is some downregulation of your HPO axis, there's a higher chance you actually get a uniform cohort. So you may get a smaller number of eggs, but then the M2 rate is higher. So that's because there was a preceding downregulation of your HPO axis, and then you are recruiting a uniform cohort of follicles. That's how I would interpret it.
Yep, I would agree as well. There's another question here on, I'm using a Clara, which is a combination of Dienogest and estradiol
Yes, yes.
glarate, yeah, rather than a Dienogest monotherapy. Uh, it is a cheaper alternative, and I feel it works well in controlling endometriosis symptoms. Which is better, in your opinion?
If we're talking about the pathophysiology of endometriosis, you can see that estrogen actually can promote the uh, the proliferation of the endometrial glands. And so I'm just worried about giving a preparation that has estrogen, because then the apoptotic effect of your Dienogest may not be as sufficient on the endometrial glands. But I will consider giving Kelira if my patients are having symptoms, hypoestrogenic symptoms. So sometimes very rarely, you'd actually, even with Dienogest, see patients that have a bit of hot flushes, not as bad as GnRH agonists, but they do have some dryness and some hypoestrogenic symptoms. That would probably be the only time I would use Kelira, because really the desired effect is to reduce the estrogen exposure of these and ectopic endometriotic glands.
Yes, okay,
Yeah.
so I agree with you there. There's another question from an anonymous attendee. Dienogest, okay. Patient with endometrioma post-operation. Usually, how long can we start the embryo transfer? Thank you. How long after
So
operation, I suppose, after endometrioma? Yeah.
yeah, so actually there are two schools of thought. One is that try to get pregnant immediately after surgery. And the other school of thought, especially now with this recent evidence, like the paper from Iwami, where they preferred treating with either Dienogest or GnRH agonist prior to starting your IVF cycle. So if I would go for the new evidence, I would actually give Dienogest for at least 3 months, which is actually what was in the paper. So that's enough to reduce all the inflammation, enough to actually also probably let that ovary recover from the stress of the surgery, the bleeding, and although the effect of endometrioma surgery. 3 months of downregulation, I believe, based on the evidence, is the appropriate time to wait.
Exactly. Yeah. Another question here. Dienogest will cause oligomenorrhea or amenorrhea. How will you suggest to give the frequency and dosage? I think this is all for endometriosis.
Mhm, mhm.
I mean, I think sometimes some patients do like the menses to come or the bleeding to come. So how
Okay,
you? Mm, yes.
so I would first explain to the patient that amenorrhea is actually a desired effect,
Mm,
because the more the patient menstruates, the more there's going to be menstrual bleeding into the peritoneum, for example, for superficial endometriosis, and into the endometrioma for the OMAS. So I would say that it's very important to tell the patient that amenorrhea is a desired effect. So I would not let her stop taking it, and I would go for the recommended dose of 2 milligrams per day. There's actually a paper already on that, and the therapeutic dose is at 2 milligrams per day.
yeah, I agree. Okay. I got another question here. This is probably on your opinion or your preference. Do you have a specific preference for treatment of endometriosis prior to frozen embryo transfer? And if you do, when do you start giving the treatments?
So what I actually do right now is that right after my egg pickup, I'm going to give the Dienogest. So that's the progestin. I'm going to continue her with whatever I started her on, whether I started her on dydrogesterone as a PPOS protocol or any other protocol. Right after OPU, I would give them the Dienogest. However, because the studies on Dienogest prior to embryo transfer is a little bit scarce, and for a long time there's already been evidence about GnRH agonists prior to doing an embryo transfer. My current practice is still after giving Dienogest, a week after my embryo, or I'm sorry, oocyte pickup, I'm going to give a 11.25 milligram dose of your GnRH agonist. Now, you might ask, why give anyway Dienogest in the first place? And I do that actually because there's also some evidence that a flare from your GnRH agonist is lesser when you pre-treat with the Dienogest. So there had been some papers in the past that indicated that if you want to avoid getting a flare from your GnRH agonist, you can actually give beforehand at least 2 to 3 weeks treatment with the Dienogest so that there's already some amount of suppression of your hypothalamus. So currently that's what we're using, but yes, it's very interesting to know if we can just purely give the Dienogest and not give the GnRH anymore. And to answer your question, yes, I would start immediately after oocyte pickup.
Yes, I will agree with you that on that. Do keep any more questions coming in. For those who has any more questions, I will allow maybe two more or one more question. I got one question from to Dr. Maria. Do you find that in your practice, by giving Dienogest, the size of endometrioma do in fact reduces, and in your opinion, to what percent or how much?
Yeah, so I've actually seen patients on very long-term Dienogest, like more than 3 years, and I've actually seen endometriomas go to almost not visible by ultrasound. I know it's there, but the size is very small for me to actually appreciate by ultrasound. So it is possible. It depends on the length of time you give the Dienogest, but there are already papers saying that there's significant decrease in size, even resolution of the endometriomas with long-term treatment.
And on your personal note, how long is any of your patients on Dienogest in your experience? How long
The
for?
longest, yeah, the longest patient I've had is 7 years.
Okay.
So yeah, so she's doing very well with the we're closely monitoring her bone density and all that, and she's doing very well, except for the first 3 months she experienced a little bit of on and off bleeding, but on the long term she's not having heavy menstrual bleeding anymore, no bleeding at all, and she's very comfortable, and the tolerance is very good. There's not as much hot flushes as compared to my patients on longer term GnRH agonists. So yes, you can give the Unigest long. There are papers that says that some patients will actually, there's a significant increased risk for depression. So
Mm.
please look at this, make sure that you're aware of this possible side effect, and counsel your patients properly.
I was just about to ask that because some may complain of mood swings after a while.
Yes,
To
yes,
stop the
yes.
Dienogest because of that treatment. Okay. So since there's no more questions from the floor, I would like to thank Dr. Maria. Special
Thank
thanks
you
to
for
you.
having me.
Thank you.
Thank
It was a very fruitful and informative presentation and discussion we had. And also like to thank, special thank to our sponsor, BSV, for making this exciting session possible. We have surely learned a lot, and I hope to meet Dr. Maria in person in
you.
KL for the PSRM Congress in November. And don't forget, we after this, we do have a post-webinar survey to help us improve any of our upcoming webinars. So, to everyone, have a good week ahead. Thank you, Dr. Maria, again. And to
Thank you
all
very
my
much.
Muslim friends, advance Ramadan Mubarak, and thank you and take care. Good night.
Good night.